Let us discuss about typhoid fever. In this video, we are going to discuss what are the causative organisms for typhoid, the mode of transmissions, clinical features, and mechanism of actions, treatment, and preventions. Typhoid and paratyphoid fever. It is caused by Salmonella typhi or Salmonella paratyphi. This results in the systemic illness. Its mode of transmissions is fecal-oral route. It is most common. Contaminated food and direct person to person. Even a handshake can transmit typhoid. So be far from the typhoid patient. How it occurs? After the oral uptake of the Salmonella typhi or Salmonella paratyphi, the number of organisms must be 10 to the power 5 in number. It reaches the distal ileum, the pear patches. There occurs proliferations in the macrophages and it enters the bloodstream, shedding liver, spleen, and gallbladder. This is primary bacteremia, then it results in the septicemia, systemic illness. Let's see the clinical features. The incubation period is 5 to 30 days. It occurs in first, second, or fourth week. In first week, we can detect typhi in blood. In second, in agglutinations by Weddell test. In third, in stool. In fourth week, in urine. During the first week, the temperature gradually rises. There occurs relative bradycardia. With 1 degree rise in 1 degree Fahrenheit rise in temperature, the heart rate should rise by 10. But in relative bradycardia, the heart rate doesn't increase by 10 beats per minute with 1 degree Fahrenheit rise in temperature. There might occur constipations or diarrhea. Diarrhea is generally foul smelling like pea soup. During the second week, there occurs persistent fever with no chills, rose colored spots, rosy spots, usually around the umbilicus, coated tongue, yellow green diarrhea or obstipations. Obstipation means painful diarrhea or painful stool. Delirium coma. It might occur delirium coma because salmonella can cross the blood-brain barrier. During the third week, the clinical features are those are which are present in second week, plus there might occur GI ulceration, pear patches perforations, hepatosplenomegaly, and rarely it might cause meningitis, myocarditis, or renal failure. So how can we diagnose? It is diagnosed by blood culture. It is the most important test for diagnosing the typhoid. It can be diagnosed by stool culture, bone marrow culture. Bone marrow culture is the most sensitive, but generally it is not done. And we have serology, Weddell test. It is less effective, less sensitive. It is not recommended. It is the test which detects the antibody. It is less effective because in patients who has previously typhoid and resolved, the test might become positive. So these days we do not recommend, but most of the hospital prefer Weddell test for typhoid. For treatment, we have got fluoroquinolones group of drugs, tablet ciprofloxacins. If not resistance, we can use, or tablet orfloxacins 400 mg. Cipro is 500 mg BD for 10 days, or we can use cefixime 200 mg BD for 10 to 14 days, or we can give 400 mg BD for 7 days. Tab azithromycin 10 to 20 mg per kg per day. Maximum its capacity is 1 gram per day. But if the patient has resistance to quinolones, then we should, and prolonged fever with depressed consciousness, organ dysfunctions, then we should give injectable ceftriaxone 2 grams OD for 10 days, or we can give cefotaxime 2 gram OD for 10 to 14 days. If severe typhoid with CNS involvement like meningitis, we should give IV dexamethasones. Its dose is 3 mg per kg bolus with 8 doses of 1 mg per kg 6 hourly. But if the patient has not CNS involvement and we give dexamethasone, then it might cause perforations of the hollow viscous in the abdomen. So we should be aware while using dexamethasones. If there is a term called drug resistance, in this case we can use if the patient is resistant to fluoroquinolones or cephalosporins, then we should go for meropenem 1 to 2 gram IV 8 hourly 10 to 14 days, or we can go with piperacillin plus tazobactams 1.4 gram 8 hourly. Or in case of ileal perforations, we should start broad spectrum antibiotics for peritonitis and refer this case to the surgery. How can we diagnose peritonitis? Generally, the typhoid has relative bradycardia. If the patient is tachycardic with typhoid fever, then we should suspect peritonitis and do erect abdominal X-ray. If we do X-ray, then we can see the sum of the gas or below the right diaphragm. It is the diagnosis for the peritonitis. We have the term called salmonella, chronic salmonella infections. If the patient is suffering from typhoid and he doesn't get any treatment and it resolves without getting treatment, the stool culture becomes positive 12 months after overcoming diseases. Then it might colonize the gallbladder, resulting in the gallbladder cancer. It might cause gallbladder cancer. And for this, we have the treatment ciprofloxacin 500 mg BD for 6 weeks. And we should ban those patients to work in the food industry, because from the food industry, all patients, all the people might be the victim of the typhoid. Let's see the preventions. For preventions, we have got vaccinations and food and water safety. In vaccinations, we have got inactivated and live. Inactivated vaccine is polysaccharide capsule injections intramuscularly 10 days before the travel, and second vaccine is given after 2 years. And we have got live vaccines. It is given 4 doses of 1 capsule at 48 hourly 10 days before the travel. And we have the trick how to suspect it is either caused by typhoid or paratyphoid. If the patient has fever, then it is most commonly by the typhoid, but if the patient has diarrhea, then it might be by the paratyphoid. Thank you.